Can you all see the screen?
Yeah,
Yes.
yes, sir.
We're good. Great. Santush, thank you so much for organizing this. And I echo Bob's remarks that hopefully next year we can all meet in person to enjoy each other's company. So, after we've heard all these wonderful lectures, the question does arise as to where we go with medical treatment in the future. I have no financial disclosures. The slide here has been demonstrated before. There are all sorts of available targets now for treatment, and consequently, we have the ability to, with steroids, suppress the entire inflammatory response. NSAIDs are a little bit more specific, targeting COX2. TNF alphas go after the PGE2 targets. We have tocilizumab with IL-6. Rituxan B-cell depletion overall is a very effective drug, not only for thyroid eye disease in our experience, but also for other autoimmune diseases. The Tepro we've heard a lot about today with its IGF-1 receptor effect. But I'm being asked to talk about radiotherapy. And radiotherapy has some very interesting effects. While it does not affect particularly the activated lymphocytes, it does prevent those lymphocytes from secreting uh, the proteins that are participating in the inflammatory matrix. And perhaps even more importantly, they cause terminal differentiation of the progenitor fibroblasts in the orbit. And since we've already learned about how important the fibroblasts are within the orbit, these pluripotential fibroblasts, if rendered routine and uninteresting, could very well be the most important effect of radiotherapy. Secondly, what factors do I think are important in evaluating the effectiveness of thyroid eye disease treatment? Well, I think you need to measure the modulation of the disease, the degree to which it can suppress activity or progression. That's what normally is measured in terms of CAS, in terms of proptosis reduction, motility changes. But more importantly, to my mind, does it modify the disease? Can it durably suspend the active phase? Does it reverse the clinical features? And probably as a surgeon, does it reduce the need for surgical intervention? And then, of course, we need to take into account safety and cost. We see in this graph, and just to point out that modulation takes the Rundle's curve down the y-axis, but modification, the more important point, takes the curve to the left on the x-axis, decreasing the duration of activity and therefore the irreversible effects of the disease. How can you identify disease modification? Well, the interruption of the anticipated disease progression, again, over a course of about a year to a year and a half of activity, the prevention of disease relapse with the withdrawal of the agent, and the need, again, for surgical rehabilitation. So let's look at a couple of treatments that we're very familiar with. Well, to begin with, the most commonly used corticosteroids, and more commonly, more recently, among the intravenous route. Here, a UGOGO trial in 2012 demonstrated in 3 different subgroups that CAS was reduced, not surprisingly, more drug, lower CAS. But there was a full 1/3 reoccurrence of thyroid eye disease, after withdrawal of the drug. In the Moritz trial on compressive optic neuropathy, intravenous steroids were used to a dose of 4 grams, and 60% of these patients still required decompression surgery. So that's not disease modification. Tepezza, we've seen, produces a reduction in CAS reliably, somewhere in the order of 3.5, a proptosis reduction of about 3 millimeters. But in the phase 2 trials, they demonstrated a relapse rate in CAS of about 30% and a proptosis relapse of about 40%. And overall, there was no difference in the number of surgeries required for the patients that were treated versus the placebo group. Rituximab has demonstrated in one very interesting study compared to IV steroids that the CAS response is better, 100% in the Rituxan group versus 70% in the IV steroid group. But most importantly, they had a reactivation rate of 0% in the Rituxan group, 30% again in the IV steroid group, recapitulating prior studies, and a lower rate of surgery. So that's disease modification. When you look at the effects of radiotherapy now, this has been around since, with the current protocol, about 1973. 1992, Chuck Leone showed that patients who were steroid dependent came off steroids if you gave them radiotherapy. In 2004, Mark Prummel showed that radiotherapy, however used in mild cases, didn't change much. Similarly, the Mayo Clinic showed that late stage disease, averaging a year and a half, also failed to show benefit. But in the Moritz prospective trial, radiotherapy versus sham treatment, there was a 60% improvement in the field of binocular vision and a 25% reduction in the need for strabismus surgery. Peter Dolman spoke about his trial, in which he looked at patients who were treated with steroids alone versus steroids plus radiotherapy. The steroid alone group had a 17% development of compressive optic neuropathy. None of the patients in the steroid plus radiotherapy group developed compressive optic neuropathy. Again, a modification in the way that the disease progresses, a shortening of the course. In our study that we published in 2017, we looked at 133 patients who were treated with a combination of steroids and radiotherapy. 104 of them were for compressive optic neuropathy. The remainder were for rapidly progressive disease or steroid dependence. These are patients, now I will speak about specifically with regard to compressive optic neuropathy, who were steroid responsive. None of them had a vasculitis or vasculopaths. They were trialed for 2 weeks with steroids. If there was improvement, they received radiotherapy, 2,000 centigrade, and then they had a taper for approximately 12 weeks to a cumulative average dose of what is the equal of 2.5 milligrams of methylprednisolone on the low end of total dose. And in these patients, a full 93% of them had a durable response in optic neuropathy, i.e., relapse occurred in only 6% of patients. And overall, only 13% of these patients went on to a stable phase elective decompression. So if you look at the data, 85% of these patients were spared a decompression surgery either on an elective or an acute basis. Only 6% underwent, again, acute phase decompressions for failed or relapsed treatment. What's the safety profile? Well, this has now been around in the current iteration for about 50 years. There has been no demonstrated increased tumorigenesis. There's a 5% chance of cataract, and retinopathy is avoided if you do not treat people with poorly controlled hypertension, insulin-dependent diabetes, or some type of systemic vasculitis. That compares favorably for two more durable uses of steroids, which we're all familiar with after 40 to 50 years of treatment. Rituxan, unfortunately, is associated with a 1 in 10,000 rate of death due to unreleased PML. And Tepezza is relatively new, so we're beginning to learn more and more about the side effects, one of which is troubling to many of us, is the hearing loss, which is now becoming more and more well characterized. What about the costs? Well, steroids are cheap. $100 for a full course of oral, $4,000 for intravenous. Decompression surgery is roughly $18,000. Again, these are all US dollar figures for Medicare reimbursement. Radiotherapy is less than half of that at $8,000. Rituxan is between $5,000 and $20,000, depending on the protocol you use. And as mentioned earlier, Tepezza is now approaching some $400,000, all costs in. So overall, I think that the data has demonstrated in a number of studies that radiotherapy shifts the activity score of the disease to the left, and that this occurs in a period of about 3 months after instituting the radiotherapy. And consequently, The severity of the disease is depressed. The irreversible components of the disease are limited, and thereby you're reducing the need for surgery, and you're changing the paradigm of treatment from surgery first to medical therapy first, sparing all but those patients who are the few that require urgent decompressions, the 6% or so in our study from an acute phase decompression. The remainder undergo stable phase decompressions on an elective basis, a far fewer number, therefore far fewer incidents of the need for rehabilitative strabismus surgery, and converting these types of patients to a quieter look. So where does radiotherapy live? It is not indicated, bear in mind, not indicated for mild disease. It has no added benefit. Late phase disease, it has no added benefit. Stable phase disease, steroid responders, vasculoplasty. And late phase disease, I should just take a moment to refine that concept. Stable phase, I think we all understand to some degree. Late phase are those patients who are close to the end of their active phase. So as I said, we all know that this disease lasts about a year to a year and a half. So if a patient shows up at month 3, 6, they're clearly indicated, 9 even. But if you see a patient at month 12, one has to begin to consider alternate measures. What is it indicated for? Acute phase disease, steroid responsive, compressive optic neuropathy. Again, like this gentleman on the right, and it was mentioned in the last talk. If you do not have a steroid responsive effect, this will not help. And this patient went on to acute phase decompression. And it can be helpful, although we don't see as many patients any longer. I no longer am using steroids ad infinitum. But if you have a patient who is steroid dependent, that's a helpful way to get them off steroids. And as Peter Dolman alluded to, these rapidly progressive orbitopathies that are congestive and are beginning to show eccentric diplopia can be managed well with a combination of steroids and radiation because it stops their disease, it reverses the congestion, and in some ways improves their motility, avoiding again the need for decompression and for strabismus surgery. Thank you for including me in this wonderful